It's my pleasure to introduce today's very round speaker, Dr. Lin. Dr. Lin is an assistant professor of nursing, psychiatry, brain and cognitive sciences, neuroscience, and neurology at the University of Rochester. She received her bachelor degree in medicine from Jilin University, PhD degree in nursing from University of Wisconsin Madison, with 5 years of research training in NIA-funded P50 Alzheimer's Disease Research Center. She also has a postdoctoral training from neurology and psychiatry from University of Rochester. Her current research has been devoted to development of neuroplasticity-based cognitive modification interventions to mitigate or prevent cognitive decline in older adults at risk for dementia and promote successful cognitive training. She is currently running a lab, CogT Lab, focusing on understanding the underlying neurophysiological mechanisms of cognitive impairment versus cognitive excellence, and designing and implementing non-pharmacological interventions targeting those mechanisms in order to ultimately prevent dementia. So she's also PI of multiple NIA-funded grants, and she's serving as an editor for 2 dementia research journals. She has also received numerous awards, including the Young Investigator Award from American Neuropsychiatric Association. She's also an Alzheimer Association invited speaker for this year's Alzheimer Association International Conference. So today, it's our pleasure to have her to talk about her research. Thank you. Can everyone hear me well? Okay. So first I would like to thank Dr. Li for inviting me here, and thanks everyone for coming to the talk so early. I know it's not very easy to do.
It's not early for us.
So I'm currently conducting a lab, like Dr. Li described, is focusing on the prevention of cognitive decline and the promotion of successful cognitive aging. So currently there are 2 major lines being conducted in my lab. And the first is the detection of early markers for cognitive decline and the new computational modeling development. So we have been primarily working with both fMRI and trying to enhance the existing AD pathophysiological assessment. And then we also start doing different kind of multimodality neuroimaging work, trying to enhance the kind of the prediction for Alzheimer's disease. So based on the finding from the first line, we also try to develop, to modify, and testing different kind of neuroplasticity-based behavior intervention. And predominantly, because of my postdoc training, I have been focusing on the vision-based cognitive training paradigms. But more recently, we also started exploring other type of cognitive training paradigms, like the auditory-oriented, as well as the non-invasive brain stimulation and neurofeedback intervention. But in today's talk, I'm going to primarily focusing on this vision-based cognitive training paradigm. And I also put some keyword here just to give an idea about the approach being used in my lab. So we primarily do different kind of MRI, DTI, T1, resting state, task-related for fMRI, and we also do amyloid PET and FDG PET. We don't do tau in our site because we don't have the capacity really to produce tau immediately in our site. And we do different kind of psychological functional assessments, and we do some peripheral physiological assessment based on the purpose of a specific project, and do different kind of data modeling, and we try to adjust a full spectrum of cognitive aging. From one end is Alzheimer's disease, to the other end we call it like supernormal or superager. So in today's today's talk, I'm going to, as I said, going to focus on cognitive training, vision-based cognitive training. So cognitive training is a burgeoning research area given its potential effect on slowing cognitive decline. So there's been a recent update from the National Academies giving conservative but optimistic view on the potential of this research area. So I'm going to briefly go over the cognitive aging, AD, and neuroplasticity, and then I will introduce a pilot intervention I finished during my K award on neuroplasticity-based cognitive training, and with a focus on discussion about a factor that affect neuroplasticity of cognitive training called basal ganglion circuit. And just a kind of head up, so I'm currently conducting 4 NIH trials or kind of neurophysiological studies, trying to have a clear understanding about this cognitive training paradigm. So the data I'm presenting here will be relatively preliminary because it's probably kind of premature for me to be here. If like in half a year, I will be able to present tons of data. As estimated, 5.4 million Americans currently have Alzheimer's disease, and AD is only one among the top 10 diseases nationwide currently is not really curable. So in this slide, it shows the cognitive trajectories in aging and normal aging and AD process. So most of the adults will go through the normal aging process, meaning they will experience mild cognitive decline, but it will not interfere with their everyday life. And for those people who go through the AD process, many people will start with the preclinical AD, meaning they don't have any cognitive symptoms. They will perform very similar to normal older adults, but they do have abnormally high level of amyloid, some type of AD pathophysiology. It can be amyloid related, it can be neural injury related. And then the second stage is amnestic mild cognitive impairment, MCI. So in this stage, people have mild cognitive deficits, primary in memory domain, and they also have some deficits in their instrumental activity of daily living function, but essentially they still live relatively independently. And then end stage dementia, in which cognitive impairment is severe enough to interfere with everyday capacity. And so there is no like linear or static relationship between this preclinical MCI to dementia stages. But so for people in the preclinical stage or MCI stage, they may progress to dementia, but they may stay in the status or reverse back to normal. So it's kind of uncertain, but also it gives a lot of opportunities to do prevention work. So this slide shows a hypothetical biomarker model for Alzheimer's disease. So far there is no consensus in terms of the temporal order of these pathophysiological markers. But in the literature, there has been accumulated evidence to suggest amyloid accumulation occurs decades earlier than cognitive decline. And the synaptic dysfunction, often measured with FDG PET or gold fMRI, also occur very early, and it's closely related to cognitive decline. And then there has been some recent hypotheses proposing that the synaptic dysfunction may mediate the relationship between amyloid deposition and cognitive decline. And this is an area we are particularly interested in terms of developing this cognitive training. And tau and the brain structure changes reflect neuron loss or injury, and the previous literature suggests neurodegeneration will interact with amyloid in facilitating cognitive decline. But more recently, some literature suggests it may actually be parallel between the parallel development of neurodegeneration with the amyloid. So there is no consensus so far. So here's just some examples of imaging modality of AD pathophysiology. So on the upper side here is the typical structure MRI through the AD process. So you can see the enlarge the ventricle through amnestic MCI to AD, and then shrink the hippocampus, and then the overall gray matter atrophy. And then the bottom side here is example about the PET MR, the PET imaging. The left side is amyloid, and the right side is the tau, I believe. So opposite to the neurodegeneration, neuroplasticity helps promote cognitive function. And the recent literature shows that neuroplasticity still exists in aging process, even in those at risk for AD, evidenced by AD pathophysiology. And as suggested by the animal model, due to neuroplasticity, the brain can be influenced by different stimuli from visual, motor, cognitive to thermosensory. We call this stimuli together as an enriched environment. Such environmental demands have potential to influence how brain process and store information and help with a large-scale brain remapping. And for the past decades, enriched environment has been the foundation for many behavior interventions based on the principle of neuroplasticity. And the recent work identified multiple categories of activities that can enrich the environment. And relevant to this talk, I'm going to briefly explain the role of novelty in the brain. So novelty related to anything that are new or challenging, which also embedded in many social activities and sensory stimulation. This is an example of rodent work here. Okay. So in this experiment, they found that compared to the standard house control, the enriched environment group had enhanced the hippocampal dendritic spine length and volume, and also prolonged exposure to the very specific type of novelty. Novelty type of enriched environment, it also significantly enhance hippocampal long-term potentiation and prevent the long-term potentiation inhibition induced by amyloid accumulation. So neuroplasticity also occurs beyond the cellular level, which can help with large-scale cortical and subcortical changes, and more often measured in human studies. So in relation to the context of cognitive aging, there has been theories emphasizing the process that can lead to brain remapping. So such remapping can occur through strengthening existing connections, forming new connections, and disusing connections that become weak or faulty. And then the example I gave here is from the scaffolding theory of aging and cognition. So it's from Park's group. So they emphasize the most critical brain region involved in the process of brain remapping is prefrontal cortex. So for example, even for long-term memory task, which is supposed to be regulated by hippocampus and other posterior part of the brain, in older adults, they start relying completely on the prefrontal cortex to maintain a relatively normal memory performance. And this is another example of how frontal regions protect memory performance against AD pathophysiology in old age. So here we examine the brain's spontaneous oscillation measured with using amplitude of low frequency fluctuation from the resting state for fMRI. So we compare 4 groups, and the interest group is the 4 groups are either with genetic risk or with has the clinical phenotype like the amnestic MCI. And the group we are particularly interested here are the group who has genetic risk, APOE4 positive carrier, but being cognitively normal. And then we compare this group with the other 3 groups, which are either genetic risk with AMCI or no genetic risk MCI, or just being a healthy control. And we are interested in understanding, so what helped this particular group to maintain their memory capacity in spite of their genetic risk. And we found the high oscillation of 3 frontal regions that kind of differentiate our interested group from others. So they are the insular, inferior frontal drivers, and precentral drivers. And furthermore, the oscillation in the insular and inferior frontal drivers also moderate the relationship between amyloid accumulation and the memory performance. And then the amyloid we measure, we use the CSF measure. So the lower amyloid in CSF reflecting higher level of amyloid deposition in the brain and related to lower level of memory performance. But what we found here, for those for the group who has high oscillation in these frontal regions, this relationship between amyloid and the memory get disrupted. So it just provides another aspect of evidence to suggest the potential protective role of these frontal regions in cognitive aging. Then, different from the cognitive aging process, by studying a group called the supernormal or superagers, who have maintained excellent cognitive capacity over decades, we found that they are not unlike these cognitively average agers mentioned in the previous slide, relying completely in the frontal regions. They are semi-like the young adults who utilize many of their posterior brain regions, but meanwhile they have their own unique neural characteristic by relying on the network between the anterior and the posterior regions. So the upside here is a cross-sectional study we conducted before. So what we found, we just assessed the functional connectivity, and we found, compared to the average ager control, supernormal has significantly stronger connectivity within the posterior regions, like between the posterior cingulate cortex and the precuneus, as well as the stronger connectivity between the anterior and the posterior part, which is the anterior cingulate cortex and hippocampus. And then this is a follow-up study, is a kind of 1 year apart, 2-time assessment study we did, and we just finished recently. So we still compare these two groups and try to identify whether there are any longitudinal stable pattern in supernormal that differentiate them from their average ager control. And we found multiple regions, both anterior and the posterior regions. So compared to this average control, supernormal had a significantly higher oscillation in several posterior regions, like the medial temporal gyrus and the right fusiform gyrus, as well as lower oscillation in some anterior regions, like anterior cingulate cortex, middle frontal gyrus. So it means to involve posterior regions in supporting cognition is still possible in aging process. So now we know we may rely on an enriched environment, especially novelty, along with the prefrontal region to do neural compensation and maintain cognitive function. Then what exact ingredients are necessary for developing an effective cognitive training paradigm that can spread out the training effect from the anterior regions to the posterior regions and be effective for group at risk for AD? So according to our previous work, attention and processing speed seem to be embedded in, literally in every aspect of cognitive and functional well-being across cognitive aging spectrum, and help differentiate groups at different cognitive stages. And these two cognitive domains also decline very early in both normal and abnormal aging process. So this can be a fundamental component in cognitive hierarchy. And the second, there are also some known neural underpinnings of an interaction between the visual attention and processing speed and higher order cognitive functions. So the relationship between the prefrontal cortex and the visual system are bidirectional. So it provides the possibility of regulating prefrontal cortex via visual system when we are aware of the visual system remain relatively intact in groups at risk for AD. Also, we talk about the critical role of prolonged exposure to novel environment in animal model. Then in human studies, similar to that, it often requires a mismatch between the functional supply, which is the person's preserve the brain or cognitive function, and the environmental demands, which is the intervention we provide. So since individuals preserve the function can be dynamic, the intervention we provide also need to be tailored to the constant functional change to ensure an effective mismatch. In terms of the intervention, Lofton's group also emphasized the intervening cognitive process help better ensure such a mismatch compared to intervening cognitive structure or representation. So they use an interesting analogy here to like physical training. So the purpose of modification should not be just training a specific set of muscles, just like a specific cognitive structure or representation. So we should actually train a dancer, which is the cognitive process here, who can successfully coordinate skills, interplay across multiple generalized and specialized systems. So far, this is the literature on cognitive process-oriented cognitive training paradigm. So most of this has been completed in healthy older adults. So basically, attention, speech processing, working memory, these three domains, and they also test the video game, but it didn't really work well. But the multimodality seems like very important for this kind of cognitive training. So our suggestion is to combine the attention and the processing speed type of training for our own testing purpose. So recently, I finished a pilot intervention trial as part of my K award. You call the vision-based speech processing training, VSOP training. This is a computerized cognitive training synthesizing multiple ingredients I discussed before. The training relies primarily on visual stimuli, practice multi-domain of processing speed and attention. And then the computer component provides the possibility of giving an automatic adjustment of the difficulty level and the reaction speed to ensure an effective mismatch. And then the person can always practice at their maximum cognitive capacity. And the VSOP training package included 5 different tasks, but all conceptually share the visual attention and processing component. And here are 2 of the 5 examples. So this one, participants have to keep tracking the target and ignore the background distractors. And they have to identify what are the 2 targets. With the increase in the difficulty level, there will be more target they have to track, and the background and the object will become more similar. And then this one here is divided attention. So participant has to pay attention to what is the object in the center, is a car or a truck, and then where is the 66 row sign in the peripheral. So this is a pilot randomized control trial. We compared the vision-based speech processing training with an active control, which is the computerized mental leisure activities, which are just an activity older adults play a lot in their everyday life. So we did a 6 weeks training, 4 hours per week, 1 hour per session, and we randomized total 24 participants into one of these 2 groups. And we do assessment at baseline and 7 weeks. So in terms of the primary cognitive and everyday function outcome, so for VSOP group, we found significant improvement in terms of the reaction time in this useful field of view assessment, which is an assessment for visual attention and processing speed. So this is the trained domain we talk about. So for this, so this assessment is conceptually similar to the VSOP training package, but in terms of format, it's completely different. And then the others are we call the transfer domain, so they were not conceptually or in terms of format similar to any of this training paradigm. So we found the VSOP group also significantly improved their working memory performance and improved the time to complete the several instrumental activity of daily living function, which is the cognition-relied, demanded everyday function. But we did not see any improvement in verbal fluency or cognitive control. And we didn't find any improvement in active control group. And next we did a group by time interaction and found compared to the control group, this significant improvement in these 3 domains remained for the VSOP group. In terms of the neural network outcome. So given the small sample size, if we only primarily examine two typical default neural network, both seated in prefrontal cortex and compromised early in AD process. So this one is central executive network, predominantly anterior regions oriented. So in MCI group, like this group at risk for AD, we often see they have an enhanced stress in this kind of neural network because of the decreased neural efficiency, but they still have to compensate for the cognitive loss. And then the second network is the deformable network, which is a network between anterior and the posterior part of the brain. And in MCI stage, we always see this disrupted stress of this network because of the disruption between the anterior and posterior regions. And in this study, we found for the central executive network, there was significant modification of the central executive network from the intervention group. And then there is also a significant, but there is no significant group by time interaction for this network. For the deformable network, we did not see any change for the VSOP group. However, for control group, there was a significant further decline in this network. And we also see a significant group by time interaction. So it means compared to the active control, the VSOP group at least was able to maintain this deformable network. So it means, but compare this slide with the previous slide, the cognitive improvement, it means probably merely maintaining deformable network after VSOP training will not help fully explain the transferring effect we found from the improvement of this cognitive function. So we need to understand the factors related to the transferring effect of training, since this is the most clinically meaningful aspect for any cognitive training. So, and it will help lay the foundation for further enhancing the effect of cognitive training paradigm. So we are particularly interested in the frontal basal ganglion circuit, which is one of the most common pathways transferring dopamines. It helps connect the anterior and the posterior regions and links to multiple higher order cognitive function. So recent work also suggested to ensure the transfer effect of cognitive training, we need to somehow modify some component within this circuit, like striatum. And here I just give some example about this neural circuit's relationship with different cognitive domain. So it's related, it has been involved in learning, inhibition, working memory. So mostly are executive function related domains. So relevant to the function of frontal basal ganglion circuit, we recently examined the multiple behavior and the physiological factors that are dopamine relevant linking to this circuit. And all of this will help understand in the future how we can further modify the existing cognitive training paradigm. So the first behavior aspect that we examine is the neuropsychiatric symptom like depression, anxiety, apathy, agitation. So this kind of neuropsychiatric symptoms are very common in group at risk for AD or developed AD. So in this study, we apply pattern analysis and identify 10 brain regions, and most of them are involved in this frontal basal ganglion circuit, like the caudate, middle frontal gyrus, and they are related to these neuropsychiatric symptoms. Based on the 10 regions, we created the individual profile combining the weight of the involved region as well as the strength of the connectivity, and use this individual profile, we were able to predict or relate to each of these individual neuropsychiatric symptoms. But also across the 10 regions connectivity, we were also able to predict the multiple neuropsychiatric symptoms as well as AD pathophysiology and their longitudinal change. And then the second behavior dimension we measured is locus of control, which is how all the adults perceive their own capacity to control their cognitive function. So we also found the regions involved in the frontal basal ganglion circuit, such as midline or anterior cingulate cortex, related to the locus control. So on the left side here is the resting state functional MRI study, and in which we found the locus control mediated the relationship between this frontal basal ganglion circuit and the cognitive function. And also this relationship is more relevant in group with AFCI compared to healthy control. And then the right side here is the one-method track DTI study, in which the functional and the structural collectivity of the frontal basal ganglion circuit seem to be coercive in supporting the locus control. And then the functional connectivity also mediated the relationship between the structural collectivity of this circuit and the locus of control. And then the third aspect of behavior factor we examined was called central fatigability, which is an older adult's perceived fatigue level, kind of a dynamic status after they participate in engage in a cognitive task that requires sustained mental effort. So we correlated the central fatigability measure with the resting state functional activity data and found so the brain map is very similar to most of the regions are frontal basal ganglion circuit related. It was a preliminary study and the sample size was very small. So following this, we currently actually are doing some more explorations about this relationship by adjusting, kind of modifying the brain regions involved in this circuit. So we use the transcranial direct current stimulation TDCS to modify the dorsolateral prefrontal cortex and try to understand whether modifying this brain region's function can help reduce central fatigability. So this is a brief protocol. So we assess central fatigability before and after the 40 minutes cognitive task, and then we give TDCS stimulation in the last 20 minutes, since it will be in a period more fatigability will be generated. And we give 1.5 milliamp current in the DLPFC. So here are just some preliminary analysis with only 6 subjects. This analysis we did like a couple months ago. What we found is compared to the sham condition, in actual stimulation condition, we observed a non-significant trend different between these two conditions. So so this is really preliminary, and we are currently trying to finish up the data collection, which will include about 30 subjects, and the actual data will be analyzed next month. But it seems like potentially have kind of promise in terms of modifying the central fatigability by modifying the function of the DLPFC. And I also initiated a series of studies adjusting the bidirectional relationship between the autonomic nervous system and the regions involved in frontal basal ganglion circuit, because in the literature we know the autonomic nervous system regulated by several regions like prefrontal cortex, amygdala, and insula, and they are relevant to this circuit. So this is one example of the study we did recently. So we examined the relationship between this frontal basal ganglion circuit and autonomic nervous system in the context of AD neurodegeneration. We measured the cortical thickness of several brain regions that are very sensitive to AD-associated neurodegeneration. And then we found the region ACC, anterior cingulate cortex in particular, kind of mediated the relationship between this AD neurodegeneration and the autonomic nervous system's function. And then relevant to this piece of work, in my K project, in addition to understand the training effect of the cognitive training paradigm, we also examine the relationship between the training effect, the frontal basal ganglion circuit, and the autonomic nervous system. And then the assumption is that those who are more attentive to the training will have more dynamic autonomic nervous system response, frontal basal ganglion circuit efficiency and the better cognitive outcome. So after training, the VSOP group had a significant change in this circuit, and the change of the circuit was significantly related to the cognitive improvement. And we also assessed the autonomic nervous system response during the 6-week training using ECG. So the response to training indexed by this called high-frequency heart variability, which is parasympathetic nervous system related. I'm not going to explain why, but this is kind of focus of our interest. So this response pattern to the 6-minute cognitive training can be divided to 2 stages. So suppression stage, which often occur when people has to adjust to very difficult cognitive challenge. And then the rebound, which often happens in the stage when people are adjusted to the cognitive challenge. So we only see this U-shaped pattern in the VSOP group, but not in the active control group. And then there was also significant difference between these 2 groups in the quadratic term of this U-shaped pattern. And importantly, this quadratic term, so the U-shaped pattern was significantly related to both autonomic nervous was significantly related to both cognitive improvement after the cognitive training, as well as the change of the frontal basal ganglion circuit. I only give one example here. So in summary, the frontal regions participate in cognitive compensation in aging and AD process. Posterior brain regions and their network with frontal regions are critical in supporting excellent memory. The VSOP training produced trend and some transfer effect in older adults. And the frontal basal ganglion circuit may be sensitive to behavior changes and as well as the physiological change in autonomic nervous system in AD-associated neurodegeneration. And it may help explain the broad effect of cognitive training. And this aspect should be considered in later training modification. So we are still trying to refine the specific role of this behavior or physiological aspect in relation to cognitive training task paradigm. So there is a long way to go. So as I mentioned before, we're still trying to figure out a lot of pieces in this puzzle from my K award, which is just a pilot intervention study. So we are working on multiple aspects currently. So this is R1. We are finishing up very soon. So the enrollment will be ended next month, and the whole data collection will be ended next June. And we expanded just my K award into a large clinical trial, and trying to assess multiple cognitive and imaging domains, as well as a better understanding about the autonomic nervous system and the prefrontal region-oriented networks. And we will also extend the follow-up to 6 months. And then the second is the TDCS project I just mentioned, and the data collection will be ended next month. So there will be a lot of interesting report to follow. And then the third is a new R21 we just started 2 months ago. We trying to incorporate this local self-control, so how older adults perceive their control capacity of cognitive function into the VSOP training. And then the last one is the one we just started last month with Dr. Feng Vankee here from School of Nursing. So this is a combined intervention of this VSOP training with aerobic exercise to understand the potential synergistic effect on slowing Alzheimer's progress. So, I mean, we have done a lot of work like in the past 4 years since I started my tenure track in 2013. So it's really a group effort. So here are all my scientists, postdoc, PhD students, lab managers working in the project, and here are all my funding to support all this exploration so far. So thank you.
So we have some time to take questions. Okay, I have a question. So based on your research, and then the games that you have developed. So what would be your recommendations for at least some game that, older adults can access now so that they can, hopefully use that to maintain their, cognition. Like my mom,
Keep a job.
my mom likes to play certain games, but I think it's not listed or it's not as, interactive as the one that you have.
Yes, I mean, this was the question like most people ask when I went to AIC conference this July and giving a talk about this cognitive training stuff. So I really do not agree about using too much commercially available software until we have a fully understanding about all this software. So I think at this point, at least we know all these mental leisure activities can somehow at least help keep one person being active. So before we can really fully understand all this mechanism, I think this is the only way I can recommend. But you can see like in my Pilot K award, we defined that our training has significant better improvement for cognitive function compared to these mental leisure activities. But we have to wait, to be cautious and wait to see how the result come up this time. So,
yeah. Dr. Lin.
Hi. Nice presentation and very exciting work you're carrying out here. We work in the area of in schizophrenia, and one focus of cognitive training in schizophrenia has been a similar approach in terms of sensory processing, whether it's auditory or visual. And I'll just tell you one result of this, and I'm curious how it applies perhaps to your population. A study was done in which everyone received the sensory processing training, and they looked at similar measures in terms of working memory and other outcomes to look at transfer. And what was interesting was that it was only those, and maybe this isn't that interesting, but it kind of makes sense, it was only those who had an impairment in sensory processing that actually benefited from the sensory processing training. And I was wondering if you have any hints about that in terms from your work. I know the work, you're still in the midst of the trial, and your pilot study was relatively small. But this aspect of, as we think about personalized medicine and targeted type of training, what's the benefit?
okay.
Who benefits from it, or do we know that yet?
It's really a very good question. So I think in terms of the sensory, so first the vision system, I'm primarily focused on vision system because it has a clear pathway compared to auditory system. It's kind of relatively messy at this point. And we actually, there is a RFA just come out to understand the auditory system, how it relates to the central nervous system, and we are going to submit a grant actually next month. So from my perspective, I feel the personalized medicine is really important, and but it really depends. We have to build a comprehensive profile for each individual. So sensory, like including the auditory vision part, can be part of the profile, but they also probably have to be multiple cognitive domains and the net preference, so many different things. So for, like you said, like for some people, they only people who has improved their sensory, also improved their cognitive function. I'm not sure whether it's very specific to schizophrenia, but it may be actually in the same case for a proportion of the older adults we see in general, just because they have this sensory impairment, so improve it helps correlate to transfer the improvement to cognitive function. So, but I think, so my point is, so it can be one component, but meanwhile, we also found in just normal older adults, if people has lower global cognition from the active trial, they will have greater improvement after the intervention because there is a greater room for them to improve in this cognitive domain. So it may be the same story here. So because they have a greater room in the sensory system for them to improve, and that's why they can apply to the cognitive domain. But just it really case by case, and you probably just have to consider many different aspects. So I don't have an answer at this point. It seems like there's so many pieces in the puzzle, but yes, but I think we do have, that's why I'm trying to emphasize here. So we are trying to like really to examine many different aspects within this phenomenon, and at this point we don't have a consensus or conclusive answer to this.
Yeah, thank you.
Back
So,
there, Eric?
Have you or anybody looked at the ApoE4 status on the effect of cognitive training?
So not in my current study, unfortunately. It's always difficult to collect the data. But I think it's a very important part, but no. So that's why, yeah. I know it's, so for us it's kind of a little difficult. But as I said, so currently the emphasis for this behavior intervention is actually more and more like pharmacological intervention, which is we have to see whether there are any change in related to AD pathophysiology. So it will not only be these brain functional changes. So that's why actually our plan for analyzing first R1 is to at least look at AD neurodegeneration, so the cortical thickness, we call the ultimate disease signature cortical thickness. So at least they give us some insight in terms of whether there will be this specific training effect for group with or without AD neurodegeneration. So it may not, it may not be like exactly the same as genetic risk or exactly the same as the amyloid, but at least it can give us some initial idea. And but meanwhile, for the new R1 Feng and I just received, we are going to add the component of assessing amyloid PET as the supplement. So hopefully it also will help provide a more direct answer compared to if we assess like a genetic risk. But it's also more expensive. We can only do a small proportion of the sample.
And also, we just submitted another R1, so we are going to measure the ApoE4
Oh, okay.
For the.
Okay.
I have one question. Sometimes when I hear about this research done in Alzheimer's, I think about why neuroplasticity was advantageous during human evolution. And it's because neuroplasticity enabled us to respond to novel and meaningful changes in our environment. And it seems like giving someone a computer game to play is completely devoid of meaning for an individual. And I wonder whether anyone's ever done research looking at the effect of maybe social what is sort of meaningful changes in our environment encourage neuroplasticity? Well, when we have a task that's practical that we have to do for survival or to be successful in our lives, or social interactions. And have you ever considered adding that element to these training programs, maybe a social element or a more pragmatic task?
It's really
and
a
to
good
see whether
question.
that improves the effect of these.
So I can answer your question from two aspects. So first, in terms of the social interaction, whether we improve social well-being can help improve cognitive function. So there have been actually a separate area of research being conducted. There is a group I believe in Michigan or in Washington, we call it Experimental Corp, so X-Corp. So it's kind of a social interaction between old adults, old aging volunteer with the kids, and then trying to see whether their interaction can help improve older adults' cognitive function. So it has been a intervention there for a long time, and then they are doing years follow-up. But because of my own research interest, so I have been very cognitive science oriented, so I haven't really done anything in that aspect. However, so currently we also have a U grant in my site. So I'm co-PI for the U grant and also PI for the project, which is we are trying to see whether this novel cognitive training they may not be clinically meaningful to these older adults, but whether it can help improve
social isolation, because we see the prefrontal cortex play a very important role in social isolation, and then there has been a serious study conducted in Yale. I think there was a very famous paper published a few years ago in Science about the prefrontal cortex role in social isolation. So we are trying to see if we can modify prefrontal cortex, whether we can actually improve social well-being. So this is another angle we are trying to adjust. But yeah, I know there has been a lot of study on social interaction directly, but just because of my area, my background, it's not something I'm comfortable to do at this point. But it doesn't mean like I'm exclude any opportunity for the future.
Well, thank you, Dr. Lee.